everybody, welcome to the New Zealand Shoulder Elbow Therapist Conference here in Arrowtown. I'm Margie Old, and everybody's going to introduce themselves and then enjoy our podcast.
Hi, I'm Pratnya. I'm a physiotherapist from Auckland.
Hi, I'm Lisa Hanson. I'm a physio and hand therapist from the Waikato, and I'm the matriarch. I'm the oldest.
Hi, Angela Cadogan, specialist physiotherapist from Christchurch.
Hi, I'm Sarah Betteridge, physiotherapy specialist in shoulders in Christchurch.
Hi, I'm Paul Timothy. I'm a physiotherapist in Christchurch.
And I'm Jane Dickerson. I'm a physiotherapist in Dunedin.
So welcome to our chats. I hope you enjoy the podcast.
Thanks so much for giving up some time for us tonight, Jeremy, for half an hour or so, just to talk about, we have got some questions lined up for you. I've been asked to introduce you, but it would take me more than half an hour to list all your credentials. So essentially consultant physio, professor of musculoskeletal research, sonographer, injector, researcher extraordinaire, probably more importantly, Kiwi born.
Oh yeah, yeah.
So we'll put a bag of pineapple lumps in the mail for you to say thanks. So
I'm holding you to that.
Yeah. So we'll get on to some of the questions.
My pleasure. Thank you so much for inviting me.
Hi, Jeremy. I'm Sarah Betteridge. I'm a physiotherapist in Christchurch here. I wanted to know if you could just give us a bit of an update on what your working practice looks like at the moment, what type of patients you're seeing, in what setting, so we have a better idea of your cohort that you're treating day to day.
Okay. I work in the United Kingdom's National Health Service. I'm not working privately. I'm only working, I am working sometimes 2.5 days a week. One of those days, my boss has deemed it as a frozen shoulder clinic. So I typically see people with stiff shoulders. Many of them I don't think have a frozen shoulder. Some do. So that, I guess, is people with a stiff shoulder day. And if they have got a frozen shoulder, if it's in the acute stages, we're allowed to inject here. And I've also have a diploma in ultrasound. And so I typically would do ultrasound-guided injections if there's no contraindications, if the patient consents as the first stage, and then fumble my way through trying different things if it's in the more stiff phases, which is always a bit of a uncertainty where you'll get them to, because injections won't work in the stiff phase. And then the other day, I don't like the term, but my boss has sort of deemed it as a complex shoulder problem day, which is my favorite day of my week. And it's people who typically have had 100 billion injections, 400 different diagnoses, have tried surgery, tried different non-surgical interventions, and I very fortunately have an hour with each of those patients. So typically we'll sort of see six people on that day, and it's sort of just trying to sort things out, and that's, of all the things that I do from a professional point of view, that's the day I enjoy the most. I still am surprised at myself how much I still enjoy going to clinical work after this period of time. And I guess part of that is because I've got a big balance in my working week. I don't know if I could do it every day of the week.
Yeah.
I'm very jealous. You've all got wine. Cheers to you all. I can't justify it at 7:30 in the morning, but this may look like coffee, but it's some white liquid inside.
And Jeremy, can you just tell me the really interesting day that you have? What are you commonly seeing in that patient group?
I think everybody's different. I'm very often out of my depth. Where I work in that part of London, it's a very interesting suburb. So the way it works in the National Health Service is you get referred to a physio service within a certain catchment area, And our catchment area on one side is very wealthy, well-off people, and the other side are very often much poorer people, very commonly refugees from Iran. And they've all got backstories that would bring everyone to tears, often bring me to tears. And so I'm very often out of my depth trying to understand what it must be like being a victim of torture, being a victim of sometimes obscene behavior from one human to another, as forms of torture. So I think a lot of the people I'm seeing have post-traumatic stress disorder, together with their musculoskeletal aches and pains, and their whole bodies are out of homeostasis. I was just emailing a patient just before we started doing this. I think their whole body's mentally and physically out of homeostasis, and I think all I'm trying to do is coach them with the skills I have back to a level of homeostasis that they can restore value, or try and restore value to their existence, sort of aiming for, what I always try and do in that group. I always try and think, when we say goodbye, what is it that I want this person to be doing in 12 weeks or a year or whatever time frame we plan? And I don't have any restriction. It's unusual in the National Health Service. I've sort of negotiated. I don't have any restriction with that group of patients in terms of treatments and time. I'm sure at some stage I will, because this country's about to go down the bath hole, whatever you call it, in terms of financially. But so if I ask for you guys to send pineapple bites or anything like that, you must send food, parcels. Don't delay. So because who knows what's going to happen here economically. Yeah. So it's sort of like what would value look like to that person in a set period of time, and try and cucumber slice a program that improves their physical well-being, their mental well-being, try to restore homeostasis to their life. And often I'm out of depth, so I require other people. But the problem is, even if I referred somebody to a psychologist or to somebody else, dietitian or whatever, we'd have said goodbye 20 years ago before we actually see that person. So I'm sort of probably out of scope a little bit sometimes, but trying the best I can. But that's a secret. Don't tell my boss I'm out of scope of practice. Living on the edge. I don't know if that answers your question, but
Yeah, no, it does. That's great. No, it's really interesting. You sound like you're doing a wonderful job in really challenging situation.
I don't know. I don't think I have better outcomes than anybody else. I'm not sure anybody does, but I just think these sort of people,
Yeah.
yeah, I just think it's sort of, these people are just at the very rock bottom, and no one's doing much for them. And the other side of the road, the more wealthy people have similar issues physically and cognitively, I guess, but it's easier for me to understand what's going on culturally, I guess.
Yes.
Hi, Jeremy. I am. If you're.
Yes,
Yeah,
I'm
yeah,
finished. Thank you.
I'm Pradnya. I'm from Auckland. So I mean, leading up to your sort of question, and I understand the complexity of working with patients who come from different backgrounds. Some are refugees, because I work in a private clinic with Maggie, but as well as in a public hospital. So I do see people who come with shoulder problems, which look like rotator cuff related pain, and I followed your work for over the years. So I guess what I want to ask you is, like, over the years, has your practice changed with rotator cuff related pain, like going away from a bit more specific exercises to overall management part of it? Like, what are your thoughts on it? How do you practice differently now than from what you did before?
Well, I started clinical practice probably before you were born, and certainly before the wheel was invented. I think the wheel was invented the same year I started practice, but nobody actually knew what to do with it. And I guess my original, what was flowing in my professional DNA back in 1821 was a very biomechanical approach to management, a very structural approach to management. And I guess if I look at myself now and look at the younger version of myself, the professional version of myself, I guess the biggest change for me, and I think this is why I still enjoy going to work, is I'm not going to work to fix people anymore. I'm not going with a biomechanical head on. I'm going with a functional perspective. So all of us need to lift and carry and push and pull and throw and catch and precision. And then, you add that to the lower limb, you need to kick and run and do all other sorts of things. So I guess what I try and do on day one is, so in my planning, I sort of have words like pushing. What level of pushing do I need this person to get to? What level of carrying do I need this person to get to? And everybody needs to pick up at least 10 kilos in order to travel on a plane or a train or a boat, to put the overhead bag above your seat. Everyone needs to pick up 20 kilos if you need to lift a suitcase onto the scales if you're flying. Everyone needs to pick up their 10-kilogram grandchild or daughter or son or whatever. So we all need a level of pushing and pulling and whatever. And I guess the way I work, and I think it's, for me, it's a really simple formula. Like I said, it doesn't work for everybody, and I'm not getting better outcomes than anybody else. But my formula is, what level of pushing do they need to get to? What level of carrying, throwing? Is it a frisbee to a grandchild, or is it a javelin in the Olympics? What level do they need to get to so they can say, I've got confidence in my shoulder, I can do the things I want to do. My ultimate aim is always, how do I exceed this person's expectation? So can I go a level higher than they said, this is what I used to be able to do before my problem started? Or and then I guess knowledge I've gained on the way about muscles and tendons and how they absolutely despise change, especially when you get older. Try and work out what's the average of the last 4 weeks of that throwing or that pushing or that pulling, and start at that level, which is often for many people very low. So the average of the last 4 weeks for a lot of even elite people is nothing. And because the biggest problem I think we can do is say to somebody, okay, let's run a marathon tomorrow. And you know that everyone who's not prepared for a marathon is going to break, tomorrow is going to be in so much pain and agony. So for a lot of people, saying to someone 3 sets of 10 3 times a day is running a marathon. So for some people, I'll say, go home, have some broccoli to try and get some antioxidants into their body. I won't say broccoli, but go home, have your dinner, and then give yourself 10 minutes in the evening and let's do some sit to stands and let's do unloaded whatever. Or even do it with the asymptomatic side, and just imagine you're doing it with the symptomatic side, with an aim that if you cucumber slice a program so the muscles and tendons don't detect change over that 3-month or whatever period of time it takes, or the first 3 months, and then you might reset it and go for another 3 months because you achieve those goals, but it's still not the final goals. And making sure you educate the person that, like, if you're trying to decrease diabetes, the blood sugars aren't going to decrease straight away, they're going to go up and down. So it's not a failure if you have a little bit more pain. It's just an opportunity to try and reset the trajectory and try and work out what other loads you can deal with. And the other thing that's super important for me, again, from some PhD students, research and stuff that I'm very interested in, is it's not just physical load that we as physiotherapists have to deal with. It's also lifestyle load. So if you've got someone who's busy doing a pushing program or a throwing program, but also having a cigarette and a Big Mac at the same time, and not sleeping well, they're probably not going to get the outcome they're hoping for, and certainly not the outcomes we would love them to take them to. So a big part of that has to be, in parallel, lifestyle load as well. And that's, so my job's simple. My job's really simple. It's not structural. I don't have to identify a structure. And I know a lot of people hate that sentence, but I've spent my whole career, early part of my career, trying to work out what structures were causing the symptoms and why. But I think we're all at a loss. And, guess today in New Zealand, it's the end of the working week, but today the people who had elective surgery on their shoulders, I would guess 50, 60, 70% of them had surgery on tissues that weren't causing their symptoms, if it was elective. And so everybody's struggling to try and work out what's causing the problem. Why don't we go back to the 1950s, which I think was a golden time in our profession, when we were all about treating survivors of the Second World War and people post-polio virus. And it wasn't about which myelin sheath do I have to fix. It's about what function can I restore to this person to give them some value in their life. Long answer, sorry.
Thank you.
Cool.
I talk too much.
Hi, Jeremy. Hi, I'm Paul. I work in Christchurch.
Hey, Paul.
We've been at a shoulder conference, which is surgeon led. So the flavour has been more anatomical, and I've got two questions. The first one is relating to frozen shoulder. That there was a talk today on hydrodilation, and I'm seeing an increasing amount of my colleagues in the UK, physios, who are starting to implement this, and I'm just wondering what your thoughts are of hydrodilation for frozen shoulder. And then the second one is the discussion today was around rotator cuff and the outcomes of physio versus surgical, and the surgeons were sort of kicking the can down the road in terms of that they were now saying that the outcomes are superior at 10 years now of surgical intervention versus physio, rather than and because at the 5 years it's the same. I'm just wondering what your understanding, or if you've got anything to add to that. Thank you.
Okay, I'm an old man. Don't expect me to remember both questions, so I'll do the one I remember. I'll do the one I remember, which is the last one. So the surgeons there are talking about the final Moosmeyer study, where they randomized people with partial thickness tears to physiotherapy or surgery. And at 10 years, using the constant score, they produced an outcome which was 9.6 points on the constant score, difference in one group, in the surgical group, than the physio group. 9.6 is not the minimally clinically important difference between, so I think it's 10 points, I believe, maybe more, maybe it's 10 points on the constant score. So yes, statistically, it was a better outcome. The study was done again around about the time the wheel was invented, and I personally think that we can do a whole lot better in rehabilitation today. But I guess if we're using the best evidence available to us and we're doing shared decision making, and we're looking at the confidence intervals of that particular study, some people will have worse outcomes than the surgical group, and some people will have better outcomes in the surgical group than the non-surgical group. That's for one particular rotator cuff condition, partial thickness tears, in one study that used an outcome measure that is not the best outcome measure for the shoulder. So there's a lot of problems with constant score. They didn't use Spady, they didn't use Dash in that study, if I'm talking about the one that they were referring to. Not that they're particularly brilliant either, but they're better than constant score. So yes, if we're going with evidence, then that would be one way to do shared decision making with the patient. I guess it's beholden on our profession, and I don't know why we haven't done it, looking at better ways to rehabilitate patients, looking at whole body rehabilitation, looking at lifestyle rehabilitation. I wonder if we would get the same or better outcomes with a 21st century rehabilitation program, not a 20th century rehabilitation program. I also wonder, there's a lot of things I wonder about that study, but if we look at other studies, so 10-year follow-ups for subacromial decompression performed by orthopedic surgeons in Finland, Sara Katola, for example. She's a very inspirational orthopedic surgeon. Her 10-year follow-up for impingement, whatever that means, says absolutely do not operate. Full thickness tears of the rotator cuff. What are we seeing in UCUF trial and other trials, that these procedures are not outperforming placebo surgery? Same in subacromial decompressions. So it's interesting to me that one condition, a partial thickness tear study over 10 years, is the only study to my knowledge that demonstrates better performance than non-surgical. But look at that, be a crime scene investigator. Look at the outcome measures, look at the minimally clinically important difference. Look at, I'm not saying don't operate. I've never said that. I've been accused of it. But if you've got something that's cheaper, less cost demanding on a health service, something that's maybe less damaging to a patient financially, in terms of time, in terms of pain, that has a very, very close chance of having the same outcome, if not better, surely spend 12 weeks doing that first. And if people are not satisfied, go and have a surgery at some point. There's no evidence to say if you delay it, it's going to have a worse outcome. So that's question number 2. Question number 1, hydrodilation. So in 1910, no, not 1910. I'm really not drinking. Yes, in 1910. What I wanted to say was 2010. I was working in a community physio service, again in the National Health Service, and we were commissioned by the health charity to set up the first complete physiotherapy-led community frozen shoulder service. So myself and my colleague were very gratefully given a huge amount of money to set up a frozen shoulder service in the community, because they thought that if it's physios, it's cheaper. And it also, in the community, it does means you don't have to access acute hospitals to save time and money. So we were given money and we were trained to do ultrasound-guided injections for frozen shoulders, but also hydrodistension. That was the remit of the service we had to set up. And we had a lot of training, and it was wonderful training, but we weren't given much support after the training finished. From time to time we were, but not a lot. And so myself and my colleague, Owen, we were doing hydrodistensions, and I could never understand, and you know the needle's in the joint because you see it on the ultrasound machine. So you're pumping in 30 mils of isotonic saline into the glenohumeral joint, and sometimes you see it expand really beautifully. And then other times you put the needle in and you look at your forearm and it's turning green and you're looking like the Hulk because you're pushing and pushing and pushing and nothing's coming out of the syringe. And you sort of think, well, I'm not up against the bone because I can see the end of the needle in the ultrasound scanner. And I have no idea what's going on. And we were asking people about, why is it working sometimes, not in other times? And getting all sorts of different answers. And then other papers were available to us, like we know it takes about 220 kilograms per centimeter squared to stretch the glenohumeral joint, the posterior capsule. And there's no way a bit of saline can, put in enough pressure at 220 kilograms of force. And then Louise Holman with Karen Ginn from Australia published their study where you give someone a general anesthetic and there's a chance that they have increased movement, maybe because of muscle guarding. Like, all of us, when we've had sore backs, we just don't have flexibility, but the moment the back's not so painful, we have more movement. So that's muscle guarding. I think that's muscle guarding when I've had back pain. You don't call it a frozen back. You just, what do you call it? Whatever you call it. And I wonder if the hydrodistensions work when it isn't a frozen shoulder. It's muscle guarding, or not work, but I wonder if you can expand the capsule, and I wonder if it's unsuccessful when you can't. Because I've certainly had many friends and colleagues over the years who've had hydrodistension. It's sort of like very popular in Melbourne, where most people I know my age have grown up. you know, at the time they were having frozen shoulders, really popular to go have a hydrodistension, sometimes complete waste of time. And I wonder if what it's doing is it's expanding the joint in people whose joint can be expanded, and it's not in those who have a contracted capsule. And that's why in 2016 I wrote a paper trying to call the condition when it is contracted a contracted frozen shoulder. It didn't get much traction, but I think the other other ones are stiff shoulders, but not necessarily frozen contracted shoulders. And so, yeah, that doesn't answer your question, but that's as good as I can get, Paul.
That was excellent. No, thank you. That was really insightful.
Okay, thank you.
Yeah.
Oh, where you going?
Oh, no, that's right.
I guess my thoughts are, hi, it's Margie here. I was just wondering around any thoughts about why they happen in the first place, these frozen shoulders, the contracted version of them rather than the guarded version of them. Do you have any thoughts about that? We
So that,
have these metabolic
yeah,
factors?
I think so, because it's sort of, I don't know is the answer to your question, Maggie, but I guess sort of if you look at Dupuytren's contracture, I was just teaching in France, and when I say Dupuytren's, they all laugh at me because I can't say it in that beautiful French way. So Dupuytren's contracture, we all agree that we can't stretch out a Dupuytren's contracture. It needs surgery, and then we can do post-surgical intervention. Is that I don't know if that's an acceptable thing to say to people living in New Zealand, but my experience is we can't. And if you stick a bit of Dupuytren's tissue under a microscope and a bit of contracted frozen shoulder under a microscope, it seems to be the same tissue. They both happen in people who are 50. They're more common in people with diabetes. So there's some endocrine hormonal thing going on. The body goes out of homeostasis and something goes haywire. The interesting thing is Dupuytren's doesn't hurt and frozen shoulder does. So is it the contraction that hurts, or is it something else happening in the shoulder that hurts? And I think the reason why injections work in the early stage in terms of movement of a frozen shoulder, although this is complete hypothesis and I can't provide any evidence to support it, so don't ask. I wonder, so we know that steroid and we know lidocaine can reduce cell populations, fibroblast populations, like Nurofen, if you call it that, or ibuprofen, can reduce tendon cell populations. And we know that in Dupuytren's and in frozen shoulder, the fibroblasts differentiate to myofibroblasts, which are contractile fibroblasts. And I wonder if the earlier the injection, because it seems to be if you can inject under 2 months, you get a better outcome. So I wonder if the main function of the injections in frozen shoulder is turning off the contraction, not stopping the contraction that's occurred, but turning off future contraction by removing fibroblast populations or myofibroblast populations. And I wonder if the other thing the injections are doing is somehow targeting the source of pain, whatever that is. But it doesn't always work, and maybe because it's not turning off the tap that's causing the metabolic changes that are leading to the differentiation of myofibroblasts, fibroblasts to myofibroblasts. And maybe that's hormonal, maybe that's lifestyle, maybe that's AGS, aggregated in glycalization and products. So, you know, I don't know. There's the answer.
Yeah.
Thank you.
Again?
Thanks very
And now
much.
you promised the pineapples. Have you sent them yet?
Yeah, they're in the mail.
They're in the mail with the check, right?
Yeah, that's right. I would send Jaffas, but they've just stopped making them, so it's really sad.
What are they still making?
Jaffas.
Jaffas.
Really? Why?
I know, bad news. Sorry, but
Well, that's
anyway.
it. I'm never coming back to New Zealand. That's it.
Well, thanks very much, Jeremy, for giving up your time. That's all been very insightful as always. And yeah, we look forward to hopefully catching up with you somewhere else. soon.
Enjoy the rest of your wine and your evening.
We
It was
will.
a pleasure speaking with you. All the best. Bye-bye.
Thank you.
Bye.
Thanks for joining us. Cheers.
Cheers.
Thanks for joining us for today's podcast. I hope you've really enjoyed this content. You found some clinically useful tidbits, and some of the content has been thought-provoking. If you have other ideas for content for these podcasts, then please reach out to me on social media. Don't forget you can follow me on my social media for some more up-to-date content. If you're looking for a shoulder brace, you can check that out via our shoulder braces on flawlessmotion.com. And if you wanted an online shoulder course, then I have a range of shoulder courses, through from an introductory shoulder course through to return to sport and a shoulder instability course. You can access these courses on margieolds.com or flawlessmotion.com. That's flawlessmotion.com. And every course comes with a complimentary question and answer session, so we can drill into your understanding of the key concepts of the course. You can also join our Facebook group, Glenohumeral Gurus, and follow along for the conversations and discussions on this page. And otherwise, I look forward to you joining us for the next podcast. Thanks for your time. Until then, stay well, take care.